Okay, welcome all. Am I audible and visible to all of you? Let me just do the mic test first. Am I audible and visible? Right. So let's take out our JCB machine, the most popular equipment. When any time there is something being dug out around the JCB machine, so many people gather to see it. So many people have gathered to see that I'm using the JCB machine to take out two systems of your medicine part, that is CNS and endocrine. Remember this CNS and endocrine are the Karan Arjun of your postgraduate entrance. The mother Rakhi used to always say, no, mere Karan Arjun aayenge. So someone who has to really clear the exam with good marks and everything should never neglect this part. That is the CNS and the endocrine part. Okay. Chalo, let's start. I will do more writing, less of PPT today's. So it will be a quick revision and I require your cooperation for this. Okay. And don't expect, yes, sir, teach this, teach that. A lot of things of teaching have been there from work from home for all of you and me also. Right. So let me pick out the very first topic that you know and we studied together, that is the seizure disorder, right? Seizure is basically being classified into two major heads, which I know as a focal seizure, and the second one is a generalized seizure, right? So focal and generalized are the two major types of seizure that we know. Focal seizure is classified on the basis of loss of consciousness or LOC, if LOC is present or if at all the LOC is absent, right? If LOC is present, then it is known as a focal seizure with the impaired awareness, right? Focal seizure with the impaired awareness. You know this name? If LOC is not there, it is known as focal seizure with the intact awareness. So these are the two things that we know, and sometimes the focal seizure may become a generalized seizure. So that is a part of the definition or the classification that is known as the secondary generalized seizure. Okay. Now, in this topic, what should you know? First, the classification. Second, what is the drug of choice, DOC. I hope you remember the drug of choice for the focal seizure, that is the Lokpal. L stands for your lamotrigine, right? Lamotrigine. O goes for the oxcarbazepine. C stands for the carbazepine. P goes for the phenytoin. And the L stands for the levetiracetam, right? So we know these. Okay. So this is what you must know, okay, in a patient of focal seizure. Generalized, quick review again. Generalized can be classified as the motor, or it could be classified as a non-motor seizure, right? The motor manifestation can be in any form. It can be a form which we have seen a lot of videos with me: tonic, clonic, atonic, right? And of course, the myoclonic type. So these are the few types of motor seizure that you clinically see in a patient. And then you get the remix version. The remix version is the generalized tonic-clonic seizure. And maybe another remix version, not to neglect, that we have studied so much and must know a topic, that is a juvenile myoclonic epilepsy. Before I forget, you should tell me the drug of choice for all these seizure type. Remember, for a patient with the GTCS episodes, the drug of choice is always considered to be the valproate. And yes, for a juvenile myoclonic epilepsy, again the drug of choice is considered to be the valproate. V for victory, V for valproate, that should be the concept in your mind. It's a broad spectrum anti-epileptic anytime, right? Non-motor, yes, we know this. It doesn't present to me with a motor manifestation. That is my absent seizure, correct? Absent seizure, you all know, has been classified as in two heads, typical and the atypical type, right? And I need not tell you guys, tell me the benefits of studying in DAMS is this, that what is the drug of choice for typical absence seizure? Yes, that's the name of my daughter, ethosuximide, because this question is so common nowadays. I've named my family members on anti-epileptics. My daughter name is ethosuximide. Okay. My wife's name is valproate, and my son name is lamotrigine. And in my family, I'm the Fenadine, the problem troubleshooter. Okay, so remember, this is something must know. Okay, this has been asked. For atypical absence seizure, drug of choice is again the valproate. Correct? So these are the must know things in a patient of seizure disorder, or in a brief, I can tell you about the seizure disorder, what you should know. Right. Somewhere guidelines that you already know in pregnancy, if I consider the anti-epileptic drugs which are safe in pregnancy, can you tell me? Yes. If you're laughing with me, you are saying or typing what? LOL. L stands for the lamotrigine. O goes for the oxcarbazepine, and L stands for the levetiracetam. Correct? So people who are knowing these topics, good. They may not write. Who don't know, they can write side by side with me. So this is something must know. One thing, how do we classify seizures? Second, what are the most preferred drugs? And in pregnancy, what are the safer anti-epileptic drugs? Okay. Now quickly I'll move into the next topic. That is the movement disorder. Movement disorder. Movement disorder. See, there are so many topics to be covered. First of all, I'll tell you one thing. So don't expect me to go into details. I'm just giving you an outline of the things that you must know. Okay. Movement disorders are basically being classified into two major heads. That is a hyperkinetic movement disorder where the movement is more, or maybe a bradykinetic movement disorder. And the bradykinetic movement disorder. Okay. So what are the hyperkinetic movement disorders? We have seen them, we have read them, we have seen so many of my videos in the class. Hyperkinetic movement disorders are what? They are movement disorders like chorea, which is a dance-like movement, don't forget, the St. Peter's dance, right? And of course, I want to highlight this also, to cause chorea, the lesion is where? This you all should know about. That is the caudate nucleus, or the caudate nucleus, or the caudate lobe of the basal ganglia. Another movement disorder which I think is hyperkinetic is hemiplegismus. Hemiplegismus also, we have seen this a lot of studying we have done. Just a quick revision. How is it looking to me? A flinging movement. And where is your lesion? Yes, that's in the gap globus pallidus. Okay. Bradykinetic movement disorder, one of the very famous movement disorder that I know is your Parkinsonism. Right? Parkinsonism or the Parkinson disease, yes. It can be idiopathic, most common type, must know topic. Parkinsonism, must know thing, that the most common type of Parkinsonism that we know is the idiopathic type. And of course, that's also known to me by the name Parkinson disease, the Parkinson disease, right? So the must know thing is this. Sorry, someone corrected me. I'm very sorry. Good. Subthalamic nucleus. People are alert. I was just checking this. Okay. So subthalamic nucleus is the lesion site for the hemiplegismus. Okay. Sorry for this. Good. You're tracking me also. I'm happy. Now, Parkinsonism patient lives in a life of what? Trap. What are the things that we know? Tremors happen in this patient. Type of tremor, I hope you remember, was the resting tremor. Resting tremor. R stands for the rigidity. R stands for the rigidity. A goes for the akinesia. And P stands for the postural instability. Postural instability. So these are the must-know topics. That one is a Parkinsonism, the most common type, idiopathic. And what are the clinical manifestations of patients of Parkinson? If I want to treat a patient of Parkinson or Parkinson disease, tell me fast, what is the drug of choice? Yes. If I ask you what is drug of choice, you have to answer me, old is gold, sir, levodopa is the best anytime, right? And of course, if I ask you in young people, what is the drug of choice that you read in pharmac? It's a dopamine agonist, right? So these are the few things that you should know. Now, Parkinsonism is this, and there's a term which is the brother of Parkinson, which is known as the Parkinsonism plus. Quick revision on this topic, a must-know topic, Parkinsonism plus. Parkinsonism plus, we have got the progressive supranuclear palsy, yes. The Lewy body dementia, yes. The multiple system atrophy, MSA, and corticobasilar degeneration. Refer to your notes once, right? So that you know the full form of all these things. Simple. Remember this, PSP, as you know, comes to me with an extended posture. Extended posture and a defective downward gaze. A defective downward gaze, right? Lewy body dementia comes to me with symptoms of Parkinsonism with one thing extra. Visual hallucinations which could be fluctuating. Multiple system atrophy comes with Parkinsonism, right? Along with autonomic instability. Corticobasal degeneration patient came to me with Parkinsonism, right? Along with what? The alien limb phenomena. Another must-know topic after Parkinson anytime is Parkinsonism plus or the atypical Parkinson. One thing you should remember why it is atypical, because these patients have got a poor response to your drug of choice that you told me, levodopa. They don't respond to it. That's the problem with them. Correct? Now, just a quick review, clinical review that you must know. What are the kind of tremors that you know? A quick review of the kind of tremors that we know. Tremors could be classified as the resting tremor that we saw where just now you saw in a patient of Parkinson disease. You could also see some tremors which is known as the intentional tremor. Okay, intentional tremor that is seen in cerebellar lesions. Correct? Then don't forget flapping tremor. Yes. Flapping tremor occurred in patients with encephalopathies. And of course the fine tremor happened in patients with parotoxicosis. Now can you tell me in the chat box if you're alert? There is one tremor which has been there which comes with a very strong family history. Family history is positive in which kind of a tremor? Answer me fast. I want a quick answer on this. This is the rapid revision problem. It is your essential tremor, a topic that you should know. Essential, must know. Essential tremor comes with what kind of a problem? Autosomal dominant inheritance in the family tree. They increase by what? A very popular topic, anxiety. Decrease by taking what? Which decreases by anxiety, alcohol, right? And of course, treatment of choice, don't forget for essential tremor anytime has to be the beta blocker. If at all there is no response, then you go in for deep brain stimulation of where? Ventro-intermediate nucleus of thalamus. Right? So please know the must know topics. A lot of details are being done in the class, okay, but still these are the few topics that you should prepare yourself before going to the exam. Right. Now let's move into the another Pandora box. That's the patient of stroke that I know. Okay, I'll do one thing for this. I'll better draw a diagram of my circular village so that I can explain a lot of things which can happen in a patient of a stroke. That would be an easy revision program now. So I've got the internal carotid artery coming from either side as a branch of the common carotid which bifurcates itself into the ACA and MCA. Okay, ACA and MCA. Good, you guys are answering. Good, you guys are correcting me also in my mistakes. I'm so happy today, right? See, this is what happens if you study, leave it the class. At the end, there will not be any kind of a regret. Okay, right. So this is what we make as a perfect circle of Willis. Correct? So this was the circle of Willis. I've quickly labeled this with you guys, and this is a must know topic. Okay, so I'm just making the circle of Willis fast for you. Right. So what I want to tell you here is not the aneurysm space. It's not the aneurysm space. I'm going to tell you something. What is going to be the deficit if something wrong happens in any one of these arteries? Remember this. Anterior cerebral artery, ACA, right? If at all there is a thrombus here or a thrombus here, there are two divisions of the ACA. One is the A1 division, other one is the A2 division. The A1 division is what? Before the communicating artery meets it, precommunal, right? And the A2 division is what? The postcommunal segment. Postcommunal segment. Very important thing, must know thing, a very commonly asked question. If there is an infarct or lesion in the A1 segment, precommunal, will you get any kind of a deficit? Answer me. I want to answer quick. There is a thrombus sitting right here in the A1 segment of the ACA, the precommunal part. Where am I going to get any kind of a deficit? Of course, no deficit. Common sense tells me this answer. Look at this diagram. We have made this together. Anterior communicating artery will give you the blood. Okay. Postcommunal deficits are going to happen. What kind of deficits are going to happen? If you remember, the cortex, the primary motor cortex, the blood supply, yes. The lower limb, paracentral lobule, the trunk, arm, forearm. And this was your Sunny Deol and maybe Hrithik Roshan with 6 fingers. Okay. That high kilo ka haath. Now you find that the paracentral lobule is supplied by the ACA, rest of the motor cortex is supplied by the MCA. So postcommunal A2 segment infarction, it does involve the paracentral lobule, correct? And in these patients we get what? Contralateral lower limb weakness, one thing, correct? Urinary incontinence, resurgence of primitive reflexes, correct? Fine. And any other thing have I missed? Yes, the behavioral abnormalities. So remember, must know thing, what would happen as a deficit in the ACA territory. But remember this, it is a postcommunal kind of a thrombus infarction, then only will be the problem. The precommunal, all is well, there is going to be no deficit. Okay. Now let's move into the MCA, correct? I'll make the MCA in this part. The middle cerebral artery for me has divided into two divisions, the superior and the inferior division, correct? These are the branches of the middle cerebral artery. Middle cerebral artery MCA has divided itself into a superior division and has divided itself into an inferior division, right? Correct. Now there is one branch which has come somewhere over here. I can just abbreviate and write for you lenticulostriate branches of the MCA. What does it supply? Very important. It supplies a very important structure present in the brain here, the internal capsule, specifically the branches for the posterior limb of internal capsule. Now you should know, must know thing, the nomenclature part. This one is the M1 branch and this one is the M2 branch. So there is a M1, M2 segment of the middle cerebral artery with me. Now if at all there is an occlusion in the M1 segment of the middle cerebral artery, what would be a deficit? Look at this now. Lenticulostriate branches are going to get involved in my patient, correct? Internal capsule, posterior limb, I hope you remember, corticospinal fibers pass through it, and my patient will come to me with what? Contralateral weakness. One thing, very correct. No doubt on this. Correct. Superior inferior division, what do they supply? Yes, my dear friends, this is a bit of an anatomy on this. Superior division supplies the frontal lobe, one, and the superior parietal lobe. What does the inferior division supply to me? The temporal lobe, correct, and the inferior parietal lobe, correct? Right. Now look at this. Frontal lobe, what all areas are supplied by MCA? Everything apart from ACA is supplied by MCA. It supplies the Broca's area, temporal has got the Wernicke's area. So remember this. There is involvement of the frontal lobe in these patients as well as temporal lobe containing what? The speech areas. The Broca's in frontal, Wernicke's in temporal, and this patient is going to have which kind of an aphasia? Global aphasia, because both the divisions are affected now finally in an M1 occlusion. Correct? Now, these patients are also going to suffer with hemianesthesia. Why? Because parietal cortex is involved finally in that. Parietal cortex is a sensory cortex. Due to the involvement of the parietal cortex here, we're going to get hemianesthesia. So these are the quick points. If an M1 occlusion occurs, what is going to be the problem? I'll take you here now. M2 occlusion, superior and inferior division. What could be the deficit? Now let's mark here. What could be the deficit? Look at this. Frontal lobe is the motor cortex. Frontal lobe goes away in the superior division, we get what? Contralateral weakness. Another thing, very important. Frontal lobe here, the superior division supplies the Broca's area. So my patient will have what? The Broca's aphasia. Parietal cortex, sensory cortex. So my patient will have what? Contralateral hemianesthesia. Contralateral hemianesthesia, right? Temporal lobe is involved. Okay, here. Not very important, but inferior parietal cortex is involved here. But in temporal lobe, there's an area what? The Wernicke's area. So if the dominant hemisphere, the left side is involved, we get a Wernicke's aphasia in these patients. Inferior parietal contains the optic radiation. So my patient will have what? The homonymous heminopia. Correct? Look at this. If at all there is a lesion in the inferior division of MCA, tell me fast. I want to answer on this. If there is a lesion in the inferior division of the MCA, will my patient get any kind of hemiparesis or weakness? No, because the motor cortex is spared here. So in these patients, one thing very important must know, no weakness, no hemiparesis happens in them. Most important thing, neurology is like this. You see a symptom, you have to do localized lesion, and this is the gist of everything of what you must know, right? Okay. A quick recap of the treatment part. If a patient of stroke comes to me in the hospital, right, and my patient has got the onset, very important. I'll put like this. A patient of stroke has come to me and the onset of stroke, which I can think as the word ischemic stroke to explain this better, is less than 4.5 hours. Less than 4.5 hours. Then what? I hope you remember ruling out all the contraindication. What do you give to the patient? A Ramban, a Brahmastra. Yes. Recombinant TPA. Yes. Recombinant TPA. After ruling out every contraindication thing. Right. If at all, one thing extra you can write that the onset has been till 6 hours. A recommendation that you can write is recombinant TPA can be used in them also. But something extra now, which I have not covered that much in detail in the class. Here, if you remember, we discussed that you give it through the IV route, right? But here you give it through the intra-arterial route. Okay? So intra-arterial thrombolysis is something in India nowadays we do, and we can take it a window period now as up to 6 hours. Anyway, if it is beyond 4.5 or 6 hours, then what to do? That means my patient has come and I cannot do an intra-arterial thrombolysis. What else can I give to my patient? I can give him antiplatelet, aspirin, and second drug, don't forget the oral anticoagulant. Oral anticoagulant. Okay. So this is the mode of management of an ischemic stroke. How do you manage them? One thing extra. Nowadays we go for intra-arterial thrombolysis also, if at all the patient has presented to you within 6 hours of onset. Okay. Okay. Hemorrhagic strokes are simple. They are easy. There is a brain, there is a skull surrounding it, there is a hemorrhage within the brain, the intracerebral hemorrhage, okay? And then there is a hemorrhage between the brain and the skull, that is an extracerebral hemorrhage. 3 layers cover the brain to the skull: pia mater, arachnoid mater, dura mater, subarachnoid hemorrhage, subdural hemorrhage, extradural hemorrhage. These are the 3 classifications. Yes, we've done them very well. Remember this, the most common type of the hemorrhagic stroke is ICH. The most common cause is hypertension, right? I hope you know. And the most common site of the hypertensive bleed is your putamen, the basal ganglia. Now, one more thing that you should know, apart from these, apart from these, what are the other causes of ICH? They can be the famous CAA. Don't worry, it's not that kagaz dikhao wala CAA bill. Don't worry, it is cerebral amyloid angiopathy, right? That occurs to cause lower hemorrhage in elderly. Okay, correct. So this is a must know. For the last 2 years in all the exams, we're getting a question on CAA. Cerebral amyloid angiopathy. Let me correct this. Remember the chronology, right? Apart from this, another cause is the arteriovenous malformation, which causes the lobar hemorrhage in young. So again, a fact to note, the arteriovenous malformation occurs in young and it often causes a lobar hemorrhage. Remember this fact again, the hypertensive intracerebral bleed, the most common site is putamen, and more often they are subcortical. Correct? So these are few things must know. Right. One must know thing I want to tell you here. If I want to go and treat a patient of hypertensive bleed ICH, I go and remove the blood, but that bleed has to be there where? Cerebellum. So remember that the treatment of decompression has to be done in a cerebellar hemorrhage only, not in a pontine putamen anywhere else. Okay. Now, Amar, Akbar and Anthony. Yes. 3 brothers from the same mother, extracellular hemorrhage, Amar, Akbar and Anthony, right? 3 people from different religion, but still living under 3 different lineages, right? If you remember, subarachnoid hemorrhage, I want to remind you, the most common cause of SCH is trauma. Second most common cause of subarachnoid hemorrhage is the perianeurysm rupture. Now just a quotation from the great book Bible of Medicine, Harrison, correct? They write like this: most common cause of SCH is perianeurysm rupture, excluding head trauma. Okay, that proves somewhere that Harrison is written by Dr. Shashi Tharoor. Maybe so much of English is there and grammar is there that it gets confused. So don't get confused. You are the Chetan Bhagat. You need to understand everything. Most common cause is trauma. Second is the perianeurysm rupture. Correct. Now, I hope you remember SDH. It occurs due to cortical bridging veins tear. So the cortical bridging veins rupture, it causes that. EDH occurs due to rupture of the middle meningeal artery. Correct. Of course, one thing extra, subarachnoid hemorrhage, what do you go and do? In a subarachnoid hemorrhage which occurs due to aneurysm, yes, what do? You go in for clipping or coiling, 2 kinds of surgeries that you do. And one must know thing, one drug which is very often given in them, that is nimodipine. Right? So this is a must-know topic, excessive bleed, must-know thing. How do you treat and what are the major causes for it? Why Amar, Akbar, Anthony are the three brothers from the same mother? Who's the mother of Amar, Akbar and Anthony? Trauma. All three bleeds, excessive bleed, their mother is trauma. So in this movie today of Karan Arjun, Neuroendocrine, we have seen Amar, Akbar and Anthony also. Good. Fine. Now let me go into another thing that you all should know about, like neurodegenerative disorders, a quick review on them. Another topic must know that you should know, neurodegenerative disorders. Neurodegenerative disorders can be divided into two headings. One, disorders which occur due to tau protein, as you know as tauopathies. Other disorders we have seen just now which occur due to alpha-synuclein known as the synucleopathies. Correct? This is must know topic. What are the tauopathies that you know? One is your Alzheimer's disease, yes. Second is his younger brother, frontotemporal dementia, FTD. Another one that we have already seen, PSP. And another brother in the family was the corticobasilar degeneration. Quick review, Alzheimer's disease happens more frequently in females than males. FTD is something which occurs more typically in males than females. Alzheimer's disease commonly occurs in the age group above 65. FTD occurs in the age group below 65. Young and old. Right. Another point here, behavioral abnormalities are typical in FTD. Memory loss is more severe in patients of Alzheimer's disease. A must know topic. Remember this topic, something basics that we are often asked nowadays on them. Synucleopathies we already know, they are Parkinsonism, correct? They are Lewy body dementia, and that is the multiple system atrophy. Every exam we get a question on this. What are the tauopathies? What are the synucleopathies? Don't forget it. Correct. Now, another neurodegenerative disorder, which is hereditary, I know, is Huntington chorea. Huntington chorea, another must-know topic. What is the must-know thing over here? The disease comes down in the family tree in the autosomal dominant trait via chromosome number 4, causing the repeat sequence of CAG more than 40 times. And I hope you remember how is the clinical manifestation of Huntington, autosomal dominant, movement disorder, chorea, along with dementia. So this is a small topic, must know. Just a quick revision on this again. What do you find here? Increase in dopamine, decrease in acetylcholine, decrease in carbonergic activity. Where, remember this, chorea occurs, we discuss under degeneration of caudate lobe. Caudate lobe lives where? Striatum. So this is decrease in the cholinergic and GABAergic activity, that is intrastriatal. Now, what is must know? Drug of choice for Huntington's chorea. That will be what? Yes, that will be what? Tetrabenzene. Okay. So this is something must know, neurodegenerative disorders, few facts to be known about them. You can fast CNS infections. Yes, we know them. They are again very short, sweet topics. Okay. They are just like Burfi, you know, movie Burfi. They don't talk too much, but a lot of things you know about them. CNS infection, pyogenic meningitis, 1. Second is tubercular meningitis, 2. Third is viral or herpes simplex virus encephalitis. Another one to add is cryptococcal. Don't forget cryptococcal meningitis, right? And of course, one more I want to add here is the neurocystic psychosis. Pyogenic meningitis, most common cause they've asked often. Remember this must know topic. Adolescent age, if I look at adolescent, I'm writing ADL here, adolescent. It's Neisseria meningitis, don't forget this. And in adults and elderly, yes, what you get is the streptococcal pneumonia, strep pneumonia. If ever they ask you the most common cause of meningitis in India is TB. India has got a national disease, that's TB. Herpes simplex virus is the most common cause of sporadic viral encephalitis, sporadic viral encephalitis. Cryptococcal, most common cause in what? HIV positive patient. And neurocystic sarcosis, not anywhere are most common, maybe a thing, but still it's quite endemic in some parts of the India. And I want to mention this also, JC virus infection. I hope you remember this. JC virus infection causes what? Progressive multifocal leukoencephalopathy, PMLE, right? So these are the must-know topics that you all should know about. Rest, CSF analysis, a quick review. CSF analysis, a quick review. If you remember, the cell count rises in them, eocytosis, right? Neutrophilic more than the lymphocytic. TBM, yes, the lymphocytic is more than the neutrophilic. Herpes simplex lymphocytic is more than the neutrophilic. The cryptococcal lymphocytic is again more than the neutrophilic. Okay. Protein rises in them. No, voice break is not there, don't worry. Okay. Protein rise occurs in them. And of course, in pyogenic meningitis, 2 arrows up, TBM 3 arrows up, viral 1 arrow up, and cryptococcal not too much. An extra point here, glucose. Glucose in pyogenic meningitis, if you remember, is very, very low, right? In patients with specifically TBM, it's slightly low. And of course, the viral, it's normal. Okay? Viral is normal. And in cryptococcal also, it's normal most of the time. So these are few facts that you should know. When someone asks me, what is the JC virus? What's the JC virus? Good morning, sir. Good morning. Welcome to DAMS. JC virus stands for John Cunningham virus. Okay? Right. So a quick review on treatment again, that is very often asked. What do you give to them? You give everything as per the age. Adolescent, I like the organism first. See, if the organism is Neisseria meningitis, which kind of antibiotic is used in them? The ceftriaxone. Is used. The strep pneumonia is the organism under watch. Yes, we give the ceftriaxone with the vancomycin. Tubercular, you give the ATT. Yes, ATT. Correct. ATT you give it for 12 to 18 months. Viral, yes, what do you give? You give them acyclovir. Okay. And cryptococcal, yes, you can just start the induction therapy with amphotericin B, yes, and flucytosine. And later on change it to the fluconazole. Yeah, what is the difference between a viral and a cryptococcal meningitis? Good question. One thing, in cryptococcal, the cell count will be almost normal. Almost normal, why? Because the immune reaction will be very poor. They're HIV positive patient. Don't you think that the cell will rise? No, they won't rise that much. So that's an important catch point here. So pleocytosis is not that bad in patients, specifically with a cryptococcal meningitis. Okay, it's very difficult. What is the thing that you do for cryptococcal? Yes, you all know India in preparation is the thing that is best to look out for the cryptococcal infection. What is the best thing to look out for HSV? That is PCR for HSV in the CSF. NCC, only one thing I want to highlight, must know topic again please. Firstly, you give steroids in them, okay, to decrease the edema, followed by your albendazole therapy. So albendazole should not come before steroid anytime. It should always come after steroid in these patients. JC virus, God only helps. Just a few facts here. Clinical features, the most common are the visual defects, and treatment is not available. Okay. Right. Now just an alarm came from Dr. Srinath that, sir, I'm going to come after 2 minutes fast. Okay, sir. Seri. Headache. Divide into two types, secondary and primary. Secondary and primary, I hope you remember them, secondary and primary headaches. Secondary headaches of various types that we know, yes, they can occur due to temporal inflammation, that is temporal arthritis. Correct? A must-know topic in rheumat. Now we'll discuss this. And pseudotumor cerebri. Okay? Pseudotumor cerebri, remember the most common cause is idiopathic. So this is another small topic to discuss. Idiopathic pseudotumor cerebri is the most common type. Okay? Primary, if you remember, primary wala, what do you have? Tension headache, the most common type. The tension headache, the most common type. Followed by the migraine, and of course the cluster headache. What is the thing that you should know about them, must know? What the type of headache they come with. If you remember, tension headache is more often a dull aching, a band-like sensation that I know. Correct? A band-like sensation. Migraine is often a pulsatile headache with nausea. Other headache is what? A retroorbital pain with what? Autonomic hyperactivity, that is lacrimation. Fine. How do you go and treat them fast? Treatment part. Tension headache, you give a tricyclic antidepressant. In patients of migraine, I'm talking about the acute attack, the drug of choice is triptans. Cluster headache, what do you give for acute attack? Oxygen inhalation. See, headache is another topic which will give you headache at the end, but must know thing is how is the headache presenting, and at the end, what is the ideal treatment for these patients. Okay? Fine. So, here another small topic to read is the neuromuscular junction. Yes, the disorder which happens over there. One disease where the acetylcholine cannot leave the nerve. Yes, that is what is known as the Lamberton-Eaton myasthenic syndrome. If you remember, it is associated with small cell carcinoma of the lung. Correct. One disease where the acetylcholine cannot really work here. Postsynaptic, what was that? Myasthenia gravis. Myasthenia gravis, right? Myasthenia gravis, remember, the most common presentation of myasthenia gravis is what? They are ocular symptoms every time. Must know. What is the first investigation that you might do? Or maybe an investigation of choice? Yes, the screening, remember this, you might do with an eye-swab test or a trophonium test. If it is found to be positive, then you confirm maybe by another specific test, that is acetylcholine receptor antibodies in these patients. If antibodies are present, remember this, you suggest me of myasthenia gravis, but if antibodies are negative in them, I go for a single fiber EMG to diagnose. Single fiber EMG in these patients, if it all shows increase in jitter, then that's quite enough suggestive of myasthenia gravis. Okay. So, drug of choice for myasthenia gravis, don't forget, has to be the pyridostigmine. Along with that, you might add something which are known as the immunosuppressant. Correct? And of course, one thing extra, thymectomy is essential. So, we'll have already done this in the class, a lot of reading on this topic. Okay? Fine. And one more thing extra is a disease which affects the spinal cord. So remember this way. Remember this way. There's no voice break actually. I don't know why you're writing this. Right. Simple concepts. Remember this. There can be a disorder which affects the spinothalamic tract in the midline, right? Can you tell me this disease which affects the spinal cord in the midline like this is the syringomyelia. Syringomyelia. Few points on this. What does it present to me with a spinothalamic loss, right? Spinothalamic loss will often result in what? Dissociated anesthesia. Fine. This is a topic that you should know in this sense that dissociated anesthesia occurs in patients of syringomyelia. Another quick fact, yes, this disease, where half of the spinal cord is involved. What is this known as? Mr. Brown or the Brown-Sequard syndrome. Brown-Sequard syndrome. This is another small topic. You should know a must-know thing in spinal cord lesions. Brown-Sequard. What happens in Brown-Sequard syndrome? I can make this in a very simple diagram to explain this. Maybe this part and this part. Diagonally opposite in the patient, I might see spinothalamic loss. This part I may see a posterior column loss, posterior column loss. This part I might see element at the level of lesion and UML below the level of lesion. Okay. So please remember this, Brown-Sequard syndrome, any section of spinal cord is the Suryavansham. Every time you open the TV Star Gold, go back and see Suryavansham today, you'll understand my point. Fine. So two things that you should know, one is syringomyelia topic, another one is the Brown-Sequard in myelopathy. Okay. Endocrine I'll do fast. Endocrine fast. There are disorders which affect pituitary, disorders which affect adrenal gland, disorders which affect pancreas. Pituitary gland, anterior pituitary, and the correct. Anterior pituitary. Yeah, the voice is same. Voice is fine actually. I don't see any problem at my end. Every time you open the TV Star, it's coming from here. Even my wife is watching it right now, live with you guys. So I'm very careful not to crack any marriage jokes today. Good. Anterior pituitary, two problems here. One is a prolactinoma. Other one is a somatotrophic adenoma. Somatotrophic adenoma. Correct? Just a quick review. I think so that should be fine. It should be fine. My apologies for this. Okay. Anterior pituitary can come to me with a prolactinoma or can come to me with a somatotrophic adenoma. Correct? Most common functional pituitary tumor, most common pituitary adenoma, anytime that you know is a prolactinoma. Don't forget this. How do you diagnose a prolactinoma? By getting the patient's serum prolactin done, which in prolactinoma patient is found to be more than 200. Of course, MRI will confirm it later on. If I want to treat such patient, what is the drug of choice for prolactinoma patients? It has to be a dopamine agonist. And if at all no response, then transnodal resection. Somatotrophic adenoma presents with what? A disorder which is known as acromegaly. Remember this, for acromegaly, the investigation to start or maybe screen should be an IGF-1 levels, IGF-1 levels, correct? Followed by the growth hormone suppression test. And of course, what is the best treatment? Treatment of choice for acromegaly anytime has to be a transnodal dissection. Transnodal dissection. Remember this. Okay. The voice is fine, don't worry. I'm talking at a very loud voice. Okay. Posterior pituitary, remember there are two problems which come here. One is decrease in ADH, other one is the increase in ADH. Decrease in ADH can be due to deficiency, that is known as central diabetes insipidus, and the second one can be nephrogenic diabetes insipidus. Increase in ADH is the SIADH that we know. Few facts to know about them. The central diabetes insipidus can be treated by what? Desmopressin. Nephrogenic diabetes insipidus can be managed by a thiazide diuretic. And SIADH is managed best by a varpans. A lot of things are there in between. You can go to the notes again and see them once. Okay. Adrenal, simple. I'll make adrenal here. The adrenal problem can be in two types. Either it can be a cortisol problem or it could be an aldosterone problem, right? I hope you remember cortisol excess is there or cortisol deficiency is there. Cortisol excess is a disease which is known as the Cushing syndrome. Cushing syndrome, correct? Cushing syndrome, when I look at the most common cause of Cushing anytime, this is must know topic is iatrogenic. Iatrogenic, correct? What is the test that we do to confirm it? Yes, the confirmatory test I'm asking you. Yeah, the confirmatory test is a low dose DEXA test for these patients. Correct. So remember this Cushing syndrome is diagnosed by a low dose DEXA test, one. And of course, the most common cause is the iatrogenic. Fine. If at all we know this, what is deficiency of your cortisol seen in the body known as Addison disease. Primary adrenal insufficiency is another topic, must know, please go through it once. Addison disease specifically. Addison disease, yes, most common cause, remember this, is autoimmune, that we know, autoimmune one, and the second most common cause is tuberculosis. But remember, must know, most common cause in India for Addison disease anytime is tuberculosis. India is our national disease. Oh, sorry, TB is our national disease, not India is our national disease. So now remember this, treatment of Addison disease has to be done by steroids. We have got a problem in aldosterone, must know topic again, aldosterone excess, yes, which is known to me as what? The Conn syndrome. Conn syndrome is a patient of aldosterone excess due to what? The adrenal adenoma. The adrenal adenoma. Correct? So remember this. How do you go and treat such patients? You can use an aldosterone antagonist in them. If at all not responding, then you can go for a removal of the tumor adelectomy. So please remember, adrenal problem, Conn syndrome occurs due to adrenal adenoma most of the time. Okay. Now this is a brief outline on the adrenal problems, and of course the pancreatic problem is only one thing, that is diabetes. In diabetes, what is required, you should read that much only, not too much of reading is required. First, you should know the classification of diabetes. How do you classify it as, right? I hope you remember, we have got a type 1 diabetes, we have got a type 2 diabetes. And there is something in between the two, 1.5 diabetes, which is classified further as KPD and LAMA. That's not very important. Just in 2017 NEET-PG, we got a question on 1.5 diabetes. Most of the time we got questions on type 1 and type 2 only. Second, you should know the diagnostic criteria for diabetes. Diagnostic criteria for diabetes, most important. Okay. After this in diabetes, a must know thing for you should be the management of diabetic ketoacidosis. And what are the precipitating causes for that? And of course, the three pathies of diabetes. Three pathies of diabetes, which I know as the nephropathy, retinopathy, and the neuropathy. This is another must know thing. And at the end, we should know something about the treatment and management part in patients of diabetes. Again, it's a very big topic. Okay. must know are the few topics which I can tell you on diabetes. But again, I'll tell you one thing, read it from pharma better because most of the questions have come on the treatment part. Okay. So, so when the class finally ends, I'm emotional outside and very happy also inside, and emotional inside and happy outside. So I believe this all should be enough for you to understand the must know things. My advice to you would be to go through the topics one, which I've told you, go through your notes again and again, revise them, and don't forget at the end the drug of choice for absence seizure is ethosuximide. Might come again. Okay. So all the best from my end, and see you guys soon, maybe face to face. We are really dying to see you face to face. And when you crack a good rank and everything, okay? Chalo, I'll hand my baton over to Macha Srinath, okay? So that he can be patiently waiting for my session to get over. Chalo, Macha, okay.